right, well, I think we are right at noon. We'll get started as I know we have a full agenda. But welcome everyone, and thank you so much for joining us for today's webinar hosted by our CDOC Lung Cancer Screening Work Group. My name is Bridget Freely. I'll be your facilitator for today's session. And before we begin, just a couple of quick housekeeping items. Please stay muted during the presentation. We will have a Q&A portion after our three presentations. You can definitely enter your questions in the chat as the webinar progresses, and we will do our best to answer all questions during this Q&A panel at the end. And just as a note, this session will also be recorded. So November is Lung Cancer Awareness Month, and this makes today's discussion especially meaningful. And in today's webinar, we'll explore the story of lung cancer in California, its impact, why screening matters, and how data collection can drive better outcomes. And we'll be doing this through the lens of our newest resource, the California Lung Cancer Story Map website, which we really hope can be a powerful tool to support and enhance your work. We can go to the next slide. I'd like to also just briefly introduce our California Dialogue on Cancer, or CDOC Lung Cancer Screening Work Group. Our work group is part of California's Comprehensive Cancer Control Coalition with leadership support from the American Cancer Society. And as you can see, we're a work group of diverse volunteer organizations really aiming to advance lung cancer screening in California. And here is a list of our current membership. Three of them will be presenting today, and our workgroup co-lead, Raquel Arias, will be leading our Q&A panel, and Shantae and Sheila from CDOC will be our producers for today, so thank you all so much. We can go to the next slide. Here is just a visual representation of all of the organizations on our work group, just to give a sense of all of the amazing players at the table that have really allowed us to accomplish so much. We can go to the next slide. Here are our amazing presenters today, and just to give you a quick overview and roadmap of where our webinar is going today. First, we'll have Dr. Sarah Gandahari walking us through the foundational data on the burden of lung cancer, including screening basics, key drivers of low lung cancer screening uptake and solutions. Next, we'll have Dr. Eliza Tong, and she will share updates on the tobacco screening in cessation and lung cancer screening HEDIS measures, as well as some tobacco cessation resources. And finally, we'll have Dr. Vallada, who will guide us through the California Lung Cancer Story Map website itself, highlighting key features, visuals, and call to actions. And then we will wrap up with a Q&A, some resources, and a brief evaluation at the end. So without further ado, I will now pass it over to our first speaker, Dr. Sarah Gandahari. And I know, Dr. Gandahari, you will have share your own slides. She is the professor of medicine and medical director of the lung cancer screening program at Cedars-Sinai Medical Center. So thank you so much, Dr. Gandahari.
Thank you so much, Bridget. Can you all hear me okay? Okay, excellent. And the slides are shown okay as well? Perfect. Thank you so much for the opportunity. Hello, everyone. I'm so excited to join you this afternoon and share with you, as Bridget explained, the exciting work that has been put into place in shaping our lung cancer story map. And I will start with some foundational information related to lung cancer in California and building the case for screening. And to start, so the burden of lung cancer is something that has been understood for some time. And unfortunately, lung cancer remains to be the #1 cause of cancer death in the US. And year after year, despite the fact that the lung cancer survival has improved slightly over the years, it still remains a huge impact across the US. California follows along. There's a lot of us in California, and given our large population, we have over 10,000 Californians who die of lung cancer every year. So for those who don't think lung cancer is a California problem, it absolutely is, and it impacts a lot of us as far as neighbors, friends, families. Someone has been impacted by lung cancer, and this is an ongoing problem and needs a lot of attention. Now, in our story map, which you will hear more and more during this webinar, there are lots of great details and information, and I'll be sharing some of these details in my deck as well, and more of it will be shared later by Dr. Vallada as well. As far as what we see in California is that there is a significant difference in terms of who and where lung cancer is seen. And so this is a map that you can access on our story map, and it shows the darker colors are the places where there's more lung cancer is diagnosed. So a lot of that is matches and correlates with similar aspect that impacts social determinants of health in many of the health conditions, and this also somewhat mimics that. The counties that we see are impacted most are some that are rural, and as far as incident, farther away from access to healthcare, and it also seems that some ethnic and background ends up to have a higher incidence. We do see it that those of American Indian as well as Black population in California have a higher incidence than we see in addition to these locations. Mortality also mimics that, and you see the darker colors as well, similarly impacted by those structural limitations and barriers that we have higher mortalities in those counties. These are topics that are very important for us to pay attention to in terms of figuring out what resources that needs to be placed and the impact that it has in that population. So let's talk about screening. Now, on the left, you see a picture of a CT scanner, and on the right, what the CT scanner can potentially show. Few minutes, no IVs, very simple. Oftentimes, you don't even have to change out of your clothes, in and out. And the way that the screening is intended is to look at those who are at higher risk for lung cancer. And those are deemed to be folks who are of over the age of 50 with 20 or greater pack tobacco use, which means equivalent of 1 pack per day for 20 years or half a pack per day for 40 years. And if screening is done, the idea would be that you would identify a nodule earlier where would be at higher option of both diagnosis and treatment. So for instance, on A, where you see like a tiny little nodule that it's seen on the cuts of the chest. So as this individual is going through the CT scanner, the CT scan takes cuts through the body, and the way that is seen is that it's as if you're looking through the feet inside of the chest. This is the right side of the lung, the right lung, and there's a tiny little nodule over here. And if this person continues to get their screening on B, you see there that nodule is a little bit bigger, and again on C, that nodule is even larger. And so in this pattern, that is a nodule that is growing and it needs attention and further evaluation. And there has been studies that have shown that when screening is done in the at-risk population, it reduces the lung cancer mortality by upwards of 20 to 24%. And because lung cancer is a condition that is associated with very high mortality, the amount of screening that needs to be done in a population is about 320 scans to save one life. Now, what does that compare to other screening modalities? So for instance, for mammograms or colon cancer screening, which are much more widely adopted, you need almost 3 times as much number to be able to save a life. And again, this is based on the fact that lung cancer has a much higher mortality than breast and colon cancer. So as far as given the finding of the data that is shown and the evidence, the United States Preventive Services Task Force came with the recommendation back in 2021 with the guidelines that I shared earlier. And because of this recommendation, screening is covered at no cost for those who are eligible. Medicare has slightly different guideline as far as coverage, and those instead of upwards to the age of 80, they cover upwards to the age of 77. And both American Cancer Society as well as National Comprehensive Cancer Network, they actually eliminated the 15-year quit date as part of their requirement, which is included by USPSTF as well as Medicare. So there are different guidelines and different coverage, which adds a bit to the complexity of what who is eligible for screening and what the screening and who benefits from it. And this is where we are currently as far as the screening, both nationally as well as California. You see the national average. We're in the mid, a little bit over mid-teens. California lags behind as far as the number of people who are eligible that are getting that should be getting screens, but they're not, is about 800 Californians, which is a concern because while we are approaching national average, we're still far behind. And I do want to caution you in terms of when you look at this data. This is one from the most recent from American Lung Association, State of Lung Cancer. And what they're using is self-reported data as is reported based on the behavioral risk factor surveillance system. And it's not actual scans, is based on what individuals have been reporting. In prior iteration of this, we were listed as having a state with the lowest number of screening, and those were based on registry data and actual scans that were be done. Regardless, whether you take the 1% of Californian getting screened or 16% of Californian getting screened, there's still many, many more who need to be screened, and we have a lot of work to do. So why is the screening uptake is low? Well, there are many factors, from fear and being worried about radiation, as people are concerned that, oh, if I get a lung cancer screening, I'll be exposed to a lot of radiation. Well, if you were to compare it to all other forms of radiation, including mammogram, it's just equivalent to a little bit over 3 times the dose that what a woman would get when they receive a mammogram. It's at a low dose, so it's a lot lower than a diagnostic CT scan, and it's and looking at even the background radiation, it doesn't even get to that point as far as a 1 year of exposure that an individual would get. Now, so that fear adds up. There's all the aspect of stigma, access to screening. You saw that there are 3 different guidelines that we follow as far as the age. Identifying patients are challenging, and Dr. Tung will talk about some of the aspect as far as tobacco use and eligibility, and the factor that has on how individuals are deemed eligible. And then there's also fear and concern about false positive and incidental findings. And providers just simply don't have time to go through all the various requirements, including a shared decision making and tobacco cessation counseling. So there is a great tool that currently exists and came out by in combination of and leadership of American Cancer Society, National Lung Cancer Roundtable, to share with folks how to go through what steps are needed to have an appropriate and impactful lung cancer screening. And this manual goes through various steps of how to identify patients, how to determine what type of screening model is appropriate for a facility, for a health system, how to refine workflows, finding ways of improving lung cancer screening conversation, and ultimately screening patients. And most important part is that just because you start screening doesn't mean that you're done. It's a constant improvement process. Excuse me. So Cedars-Sinai started its screening program in 2022. And the reason I'm bringing that up, excuse me, is that it is never too late to start screening. We, as a big system, big center, we started our screening program just a few years ago. And we had the advantage of looking at other centers, looking as to what things work and what things don't work. And while the guide that American Cancer Society and National Lung Cancer Roundtable has put out wasn't available at the time, we used similar concepts in terms of building our program. We leveraged our electronic medical record for identification. We use Epic to identify those who are eligible for lung cancer screening that have the elements of smoking history and age listed in their system. we figured that our system, being it's such a diverse set of providers, faculty, private physicians, trainees, that we needed to have a model of both a centralized navigated program and utilize and leverage video visits to make it accessible for everyone, those who are even at work and cannot make it to a screening facility, but have the option of in-person available for those who want to just see their providers and get the screening through them. Included a lot of patient education with language that is inclusive, free of stigma, and also incorporated smoking cessation as an impactful part of this process to make sure that the patients not only get screened but actually work on steps of quitting. Screening is done with the low dose CT scan, and we try to make it as easy and flexible and convenient possible for them. And use, again, resources through virtually to have a discussion after the screening is done with various experts through a multidisciplinary discussion, and to share what is the recommendation with the patient so that they can have the recommendation for what needs to be done quickly, as fast as possible. This system, while it seems comprehensive, if taken through those steps and really understanding what an individual system needs and has and resources, can be done with the use of that guide. We're excited about our progress. We continue to monitor our progress, and as you see, we started as 17 patients a month, and we're continuing to increase and RNA upwards, and we have screened over 3,000 patients since we launched the program. Now, it's what I shared with you that included in our California story map is an important tool that will be very helpful if you take a look. And we're with the remainder of this webinar, share with you some of the resources that it exists. That it's a combination of not only data but also testimonials and tools that allows you to track not just what's happening. And so it allows us to track what's happening in California, and so that we have resources both for individuals, community health worker, as well as system leaders. Now I'm going to pass that on to, I'm going to stop sharing and pass it back to Bridget for sharing the rest of the presentation. Thank you so much.
Thank you so much, Dr. Gandahari, for that amazing presentation. Our next speaker is Dr. Eliza Tong. She's the professor of internal medicine at UC Davis and director of the Tobacco Cessation Policy Research Center and principal investigator for California Quits. And Dr. Tong, I will pass it over to you.
Great. Thank you so much. And just to follow up on Dr. Gandahari's wonderful presentation, I'm going to be talking a little bit more about health systems and kind of trying to explain why isn't it happening for lung cancer screening so easily. So a lot of what we do now in healthcare is around quality metrics. So I'm going to talk a little bit about the tobacco screening and cessation intervention quality metric and how it's an opportunity for lung cancer screening. And just want to acknowledge my projects, California Quits and Tobacco Cessation Policy Research Center, were funded by a couple of the different state programs. And I'll share some lessons learned about that in this presentation from these two projects. So for why isn't lung cancer screening being done so well? You saw Dr. Gandahari show California's, kind of just at a low level of screening. It's not a quality metric yet. There's something called NCQA, which is the National Committee for Quality Assurance, and they have what's called HEDIS metrics for health plans. And so I had the privilege of being part of the technical expert panel and helping to beta test some of these metrics. So this communication, just kind of to summarize it, says, we were working on it, but it's not ready for release yet. And if you go to the website and read this excerpt of it, you'll see at the bottom part where I put the arrow, it says, during this process, concerns were raised about the readiness of health plans to adequately capture and report smoking history. And then there were other concerns too about how to document risk of potential harms with shared decision-making. So it's complicated. Other cancer screenings that we do, and I'm in general internal medicine in the clinics, breast cancer screening, cervical cancer screening, colorectal cancer screening, it's not as complicated as lung cancer screening, right? But still, it's very important to offer this to patients. Next slide. So what we do have from NCQA for a new HEDIS metric for health plans is this tobacco screening and cessation metric. Now, this isn't totally news because this is actually what we already do in the clinic setting. This is just news on the health plans setting, because what they were using before, if you look on the third paragraph, is this survey called CAHPS, C-A-H-P-S, which is what health plans use to measure pretty much like patient satisfaction when you went to see a provider in the past year. And that doesn't capture the whole population. It just captures people who were willing to answer a survey and who went to see a health professional in the past year. So the quality metric for health plans has not been something where they can even measure if their members were smoking and if they also have a smoking history that makes them eligible for lung cancer screening. So you can see trying to implement both of these measures at the same time can be problematic for health plans, but now this is a first step forward where this tobacco metric starting calendar year 2026 will be the new health plan measure for their whole population, not just a member satisfaction survey. So next slide. So I want to just share some lessons learned from our California Quits project. And we've been funded by the California Tobacco Prevention Program over the past decade, actually. And in this current contract, we were trying to promote more population health strategies. So I'll share some lessons learned from that we've been working with healthcare systems, the public hospital clinics throughout the state in a value-based care program with Department of Healthcare Services, and then also some of the Medi-Cal managed care plans, what we've learned with them as well. Next slide. So I mentioned that patient satisfaction survey, CAHPS, and this is just from one of the Department of Healthcare Services reports about some of the data from all of our Medi-Cal managed care plan for 2023. So again, there wasn't one to say how many people were screened for smoking. This was just part of that question of saying, how many members were advised, who are smokers, were advised to quit? And this is what people surveyed would say. Now, there's a lot of missing data in CAHPS because you need 100 people for for answering these questions, and a lot of health plans are missing data to have 100 smokers who happen to see their provider in the past year who were willing to answer this survey. But of the plans that did have enough data, you can see we are below the 50th percentile for people reporting that their providers were assisting them with quitting. So next slide. So that's the health plan HEDIS performance measure. I don't know if we can move to the next slide. Sheila or Joyce? I can move, okay, oh, good. That looks
Yeah,
like
it's right
movement.
here. Oh,
Okay, so let's go back to what are the public hospital clinics? What are people reporting on the clinic setting? Can we go to one more before that? So DHCS, which is Department of Healthcare Services, our California Quits team has been working with the public hospital clinics reporting on this quality incentive program. So it's all not just tobacco, there's all these other metrics that are, so UC Davis is one of the public hospital clinics doing this reporting. And so tobacco has been one of the metrics, and this has been, this is just a breakdown of what that metric looks like. And this is kind of like what is going to be in the new HEDIS metric. So looking at of your whole population, how many were screened for tobacco, and of that population of your tobacco users, how many have some documented counseling assistance, and that can be medications, that can be referrals, that can be some other way that you're documenting it. And then population 3, what is sometimes reported out, and I'll show you that in a second, is that they combine population 1 and 2 together. So you get a number, and but sometimes you don't quite know how to unpack that. So one thing we've done with our state Medi-Cal program with the public hospital clinics was say, look, a lot of people are getting screened, but what we really want to know is population 2, and please have them report that out separately. So in the HEDIS metric, they're going to report out population 1 and population 2 separately for health plans now. So we really need to see that breakdown, not just, the sum total of everything in population 3. So next slide. So I showed you what public hospital clinics are doing in California, and then this is what all community health centers are doing when they report to the uniform data system. They report out that aggregate population 3 metric that I showed you. So I just wanted to show the data, that we have in summary, which is on the public website. But our community clinics are already collecting this data. It's just that it's being reported out nationally as screening and counseling combined. So you see we kind of get in the 85 range, but you don't know which, how well are they doing on screening tobacco status and how well are they doing with counseling. So again, this HEDIS metric will help us unpack that. Next slide. And just to, so what is in tobacco history? It's complicated. So that measure I was showing you for clinics, all that we're required to do for screening is to report on the status. No one is required to collect data on pack years and when did you quit if you were a former smoker. So it get very complicated in a very, brief clinic visit. And there's 3 types of tobacco now that we need to collect, right? A lot of people are using e-cigarettes and vapes, especially the younger generation. And then pack year is a very complicated topic to explain to a patient, and we need to train our clinic staff to help collect some of this data too. And next slide. So our California Quits team, one thing we were really working on during these past couple years has been to have a solution where we can try to have a comprehensive tobacco history. And we use Epic. So if folks want to contact us about this. So this is a hard copy version of the questionnaire, but we developed an electronic MyChart questionnaire for patients to answer before they come to clinic. And then I won't get into all the details, but it seems like with our latest upgrade, it looks like it's now being auto-populated into the electronic health record system. So the second page, it's a little complicated, but there is a section for pack year history. And we tried to keep it simple, so at least there'll be some information there if people answer yes and, can then help populate those fields. Next slide. So, just a reminder, even though a lot of people eligible for lung cancer screening may be former smokers, sometimes they're living with someone who's, they're exposed to secondhand smoke because they're living with a smoker, or, someone needs help with quitting. And ultimately, that's going to be the long-term solution for them, even if their lung cancer screening, turns out negative, to reduce their risk for lung cancer. So just want to put a shout out for Ticket California, which used to be known as California Smokers Helpline for many years, but they rebranded during the pandemic because they help with people to quit vaping and also smokeless or oral nicotine products as well. And they're operated at UC San Diego. They're free. It's a free service. They coach people one-to-one for 20 to 30 minutes to get them ready for a quit plan and follow up with calls. There's also an automated text program and an app available. So go to their website, and for health professionals who want to connect with an e-referral, there's also a web referral. You can go to their website or contact me afterwards. Wonderful service. I work a lot very closely with them. So next slide. In summary, just to recap about quality metrics, which really drive our healthcare systems at the clinic level and the health plan level. This tobacco screening, it's complicated, but it's critical for lung cancer screening eligibility. So I'm hopeful that this tobacco screening and cessation metric that's going into effect next calendar year in 2026 will be an opportunity for health plans to develop their member registry on tobacco and then to work with clinics to improve capturing that smoking history data if they don't already do it themselves. And hopefully that will help make it more feasible for the lung cancer screening metric to come into the quality metric world that that we all measure our population with. And so we're already doing it in clinics. We just need to do a better job of it and incorporate population health strategies. So, the medical assistants or, folks rooming, doesn't take up too much time. And then also to remember to refer to Kick It California for their free coaching services. So just the last slide, if anyone wants to contact, you can feel free to email our team. And then there's some of the resources, and I'm sure these slides will be made available for folks to click on. Thank you. I'll turn it back to Bridget.
Thank you so much, Dr. Tong. And our last presentation today will be from Dr. Jeff Vallada. He is a thoracic surgeon at Kaiser Permanente Oakland Medical Center, a clinical professor at the Department of Clinical Science at Kaiser Permanente Bernard J. Tyson School of Medicine, and a clinical assistant professor in the Department of Surgery at the UCSF School of Medicine. And Dr. Vallada, I will pass it over to you.
Yeah, thank you, Bridget. And sorry, I'll be saying next a little bit because for Sheila. So next. All right. So when you look at this, my job for the next 10 minutes is really to kind of tell you a little bit about how we think the story map can help. I think Dr. Ganahari and Dr. Tong did a great job of already kind of incorporating that. This is just a little bit of extra repetitiveness, but for all of you, I think this slide tells a lot of what I think about lung cancer in California and what our own systems think about lung cancer in California. So if you look at this poster right here, this is of this year. So everybody on this call kind of knows what's missing, but go ahead and next couple slides or next tabs. Oh, sorry, one back. Right. So in red, it's pretty obvious to you, or maybe not, it wasn't obvious to you at all, right? To people on this call that we on the CDOC work group, it's very obvious, but this is actually not from me. This is a patient of mine that took this picture and sent it to me and said, why is lung cancer not on here for screening? So it's something to think about. Okay. This is this year. Okay. Next slide. So what are we going to do about it? This is the lung cancer story map. Go ahead and play, Sheila. Thanks. And when you click on our website, next slide. You'll see. So when you click on that website, this is what comes up. And I had to do that. That video really, in essence, and Sarah and Lisa, I know are on this call from the ACS GIS team, geospatial mapping team are on, and they put that together, and Sarah put that together. I know they're on, but that really, I like to use that because that really just highlights it all, that at least that we think so. And that's obviously, you can click on that and you can also share that, right? You can share that video to your team, but it's just getscreencalifornia.org, right? It's very, very simple. This is the homepage that it brings it to. Next. And if you click on the very front, you visit the interactive maps. And so next slide. And so the way we kind of did it, and I think it's really unique, is that you have on one side the lung cancer California story map, kind of like we call it a narrative. And that's kind of, again, whether you want to call yourself a layperson or whatnot, but maybe a family member, a caregiver, maybe somebody that knows a little bit about the health field, but aren't like super into like these maps and don't know what maps or even what geospatial means or what heat maps is. So it's on the left. So you'll click on that narrative story map. But if you're like probably a lot of people on this call that are here on this call, public health professionals, policy people, just medical professionals themselves, clinicians, you may want to go to the Data Explorer, which is these kind of geospatial heat maps that Dr. Gandhari and kind of Dr. Tong have kind of showed you. So if we go through one, we'll go to just a next step. All right, so this is an example that I would say one of my patients would go to, right? It's just the narrative story map. And go ahead and click on that video for me, Sheila. Thanks. And this is exactly, oh, I guess it does come up kind of funny. But regardless, these are what we thought was cool with this is one, you have like a little basic, like the go-to screening saves lives. You see that animation. But this is actually a patient of mine. This is what it looks like if you come to Kaiser Oakland, and we got HIPAA consents and all that stuff. But basically, and we don't show her name or whatnot, although she's fine with it. But this is exactly what it's like in real time, what that scan looks like. It's narrow for me on my screen. I don't know if it is for you, but regardless, it literally took like Dr. Gandahari said, it could be 3 minutes, but like here, at least at this Kaiser scan, I timed it. It took 1 minute and 45 seconds, no contrast. You already saw from Dr. Gandahari's, it's like 1.2 millisieverts, so it's not going to increase your radiation. It's very simple. And it's amazing how these little videos, when I've had patients talk about it, like how they can really relate to it. So next slide. Okay, but then if you click on the other one, right, the interactive explorer, the geospatial map, and this is again kind of like we're harping on it because it's not like we can say it's cause effect, but we can say associations. So again, I'm going to bring up what Dr. Gandahari was talking about. Look at the lung cancer mortality rates in Shasta County, right, and all those heavy blue. It's very obvious. I don't even think you need to be a public health professional. Like my kids can figure this out by looking, oh, the darker lines, right? But regardless. So it's pretty obvious. The mortality rates are disproportionately high. And next slide. And again, you can't say this is the reason why, but this took me 2 seconds to do, right? 2 seconds. It's not just because we helped build this. You could do it too. Literally, you just make this slide, you give this to your health, you give this to Shasta County and be like, hey, or whatever hospital system's up there, right? Look, there's only one. Again, there's ACR is American College of Radiology. So there are obviously other screening facilities out there, but the ones that are on registry data, the ones that we know are active and actually doing it, there's only one in that whole area. So you can imagine, again, I just told you mortality rates are the highest in that area. There's one screening facility in that area. I can't tell you if that's the reason why, but I can tell you there's an association most likely, right? And so we're just trying to show associations with things and how we can improve. So why not do low-hanging fruit? Do you want to start in the Bay Area to change things? We've got to do it everywhere. But do you want to start in the Bay Area where we have 1 million screening facilities where we're doing pretty well? Yes, we can do better, right? But look at the low-hanging fruit. We can just annihilate and attack that area. If you just there's so many people at risk. And I didn't show you the smoking data. The smoking data is a lot higher too. So if you look at these maps, this is just one example of how you could bring that to your C-suite. The association. Next slide. All right, so what are our calls to action, right? You've heard it over and over again, but it's important, right? And guess what? We track this. We are going to be tracking this. We will be. But like on Google, right? When you click on this and we can do how many tags, we'll know how many times you're tagging it. I can tell you right now, I'm not happy with how many times we're tagging it. Probably the majority of the tags are my tags when I click on it. Okay. I need you guys to tag on that. Click on Get Screen. That's actually a call to action. I know it sounds lame, but that's actually a call to action by just clicking on that. And we want to see how many people are going to that. If people aren't going to that, we need to do a better job. Maybe 5 webinars a day, right? I'm kidding. But anyways, and Bridget came up with this nice little one pager. Again, it's on a QR code, but it tells you a little bit more about the California lung cancer story map, or just even an update. It's very updated. Sarah and Lisa will update this if you have something. So this is something that I sent to them, and they go ahead and click on this video. This is a new patient education video I have on staging.
Nodal staging occurs after a lung cancer diagnosis is made and before treatment can be determined.
And Sheila, you can stop it. You don't have to show the whole thing.
But
you guys get the idea is that this is updated. This just came out from the American Cancer Society, and we just got this out, and we just put it right on the website. So it's constantly updated. Lisa and Sarah are always on top of it, where if I email them the next day, they'll be like, okay, we'll get it on there. So this is not one of these old websites that you go to, right? You look at the website, and it was like people that aren't even on the committee are still on there. Next slide. Okay. And then lastly, obviously, we talked a little bit about, but it also has social media toolkit. So it has the narrative story map and all that stuff, but it has patient testimonials. Like you can see here, these are patients that are lung cancer survivors that had a lung cancer CT scan. They'll tell you in their own words, it's quick, it's easy, it's painless, all that. And you can see that. But the other thing that's really important is, there's talking points for you to do it. In fact, if I want to do a little quick synopsis on me as a provider saying, how am I going to tell lung cancer screening is important as a provider? It has a little toolkit that you can do that and click on that, and it'll tell you what exactly to say. It'll read out again, updated, the USPSTF guidelines, how do you say it and what you say it all. And so we think that that's really another important aspect. Next slide. Okay. So the last points again, take home points for me is just to say that again, this is about California and that our California story map is trying to highlight what the burden of cancer disparity is in California. And that the Get Screen California is unique because it's only for California. So we can really focus on that where it's just not like lung cancer classically everywhere. Like Go2 and longevity, those are all great. ALA, they're great, but they don't focus just on California in our unique perspective. We're the most populous state. We have the highest diverse state. And even though we have the second lowest smoking rate, we have the second highest incidence and mortality rate, right? So just based on population diversity, you saw those disparities. So that's something unique that we have in California that even Alabama doesn't have, even though they may have a high smoking rate. It's different. So this website we're trying to say is it'll help you as a Californian how to improve lung cancer screening rates. And again, it's updated. We have social media toolkits, and like Bridget just did this update like a week ago, like where you can click on, LinkedIn and Twitter and stuff, and it'll bring you directly to that. So even if you just tag that right now while you guys are listening to me, you go to that website and you clicked on LinkedIn, right? It'll bring up on your LinkedIn site this website, and then you'll send that out, and that'll count, right? That'll count that you did a call to action. So that's how simple it can be. So I'll bring it over to Bridget. We're at 10 minutes, and thank you very much.
Thank you so much, Dr. Vallada, and thank you for that great information about the story map. And yes, please go to getscreenedca.org, and we want to get those clicks up because it helps with our when people search lung cancer in California, the more clicks, the more the website will show up. And just also a huge thank you to our Geospatial Solutions team from the American Cancer Society, Leora, Lisa, and Sarah. I know Dr. Vallada shouted them out as well, but just a huge thank you. This website would not be possible without them. And with that, I believe now is time for our Q&A session. Please go ahead and enter your questions in the chat. I know we got a few submitted already, but I will pass it over to Raquel to kick this off.
Thank you, Bridget, and thank you so much to our amazing speakers and work group members. We appreciate you being so generous with your time and expertise. We got a couple questions in the chat regarding insurance coverage. So first from Raymond, he says he knows lung cancer screening is preventative, insurance are covering it as such, but it sounds like he's had some issues with insurance, is still charging the patient high bill for screening, don't want to screen again when their annual is due. Is there a way to fight this or a way to help the patient? So we'll start there. Responses for Raymond.
I can take that. So the as far as currently, based on any third-party payer, whether it's Medi-Cal, Medicare, private insurance, if the patient meets the eligibility criteria of the age 50 to 77 if they have Medicare, 50 to 80, the PAC year, and they meet within the quit date. If all of those are met and a patient still gets a bill, we go after them. Like, I completely agree that once a patient ends up with a bill, it's over. And not just it's over, they go back to their provider and say, I got a huge bill. Can you help me deal with this? And then the provider is also, sometimes stops sending patients because of that. So we're very active when we hear that a patient has a bill. It generates lots of emails within our system. We go as high as it could be, and we try to fix it and get that addressed. The challenge comes in when it's really not a screening. And by that, I mean when a patient ends up getting an initial screening study, and then there is a small nodule that needs a follow-up in 6 months, even though that's still a CT scan, and I would say that that's still part of screening, that converts into a diagnostic study, and that no longer is covered because they cover one CT scan per year while they're eligible. And so when scenario is there, or if the patient doesn't have all the details, for instance, the PAC year and the quit date, then it becomes challenging. And some insurance companies may cover it and some not. And so as it is now, sort of generally we follow those guidelines as they are, and we know that they're supposed to cover it, and we essentially reach out to our billing team, and it's like, this is not right, it should be covered at no cost, and we try to get that covered for them. I don't know what the scenario was that you had explained. I would encourage to go back, and if it is patient that is meeting that criteria, to reach out to the insurance. They should cover it.
Mhm. Thank you. Yeah, and I think we would appreciate more feedback from you, Raymond, because the CDOC lung cancer screening work group, specifically the American Cancer Society Cancer Action Network, that's represented on the group with the American Lung Association Director of Advocacy. They're very interested in understanding gaps in insurance coverage, or actually right now looking at the downstream or the cost sharing for follow-up test issue that Dr. Gandhari just mentioned of, scans needed at more frequent intervals or other tests. But haven't really heard much about that annual. I'm not so surprised, but we haven't heard too much with issues about that annual screening getting covered. So you can certainly follow up with us. Any other comments about that? And then there was a follow-up question about insurance from Ariel. Actually, are we anticipating any upcoming changes in reimbursement or coverage for lung cancer screenings? And this was specifically in reference to Medi-Cal patients, probably with all the changes to Medicaid. Comments on that?
I'll take that. Hi, Ariel. I know Ariel. I don't think there's any anticipated changes. For Medi-Cal, they do cover lung cancer screening. With if Affordable Care Act is still intact, the premise is, if it's recommended by U.S. Preventive Services Task Force, then it's a covered benefit. But would love to hear any stories if there are challenges, with getting their screening covered, if there's, for example, follow-up screening.
Yes, and then the point was made in the chat just now that the coding is very important. So I just put a link into the steps guide that Dr. Gandhari mentioned, and I believe it's in our resource slides. There is some guidance there as far as coding, which is very important as well. Okay, thank you. There was another question from Michelle. Are non-smokers who live in homes with smokers or live in wildfire-ravaged areas at risk for and eligible for lung cancer screening?
So yes, Michelle, we do know that you are at risk. That is a risk factor. It's not as high as, say, if you directly smoke, but secondhand smoke certainly has been known to be a risk factor. And there's recent data to actually show out of the Northwest that their wildfire smoke is an increased risk for lung cancer. So you are correct. They are both risk factors. But as you're probably imagining, what I'm going to tell you is, unfortunately, there's no guidelines or coverage for that matter to get lung cancer screening. So even though you may say you have that, and if you don't meet the specific criteria that you saw from the 2021 USPSTF guidelines, your physician will turn you away. Every once in a while, I've had patients, in different at-risk populations be able to go to their primary care provider, and even though it's not under lung cancer screening, they're able to get them a low-dose CT scan. But again, back to the ICD-10 codes, your provider would have to put in, one, your provider would have to agree. Two, depends on what your insurance question is or what your insurance statement is, because you'd have to pay, quote unquote, with the copay. And three, I don't know what three is, but I forgot. But basically, it's so it can be done. But if they that's what three is. But if your provider doesn't know about kind of coding, or if they're in a hospital system that doesn't do that, and they put down screening CT scan because you said you had wildfire smoke, or on your chart you don't have a smoking history, you will get turned away right away. And that's where the ICD-10 codes. So you can be clever about things. I'm not saying that you should get a CT scan if you have that, but certainly that is one way that patients have been able to do things slightly differently if there are different at-risk populations. Because if you learned anything from Dr. Tong's talk and HEDIS and NCQA, and how long it takes for everything to really happen, if you want to wait to get your screening CT scan because you believe that you're at high risk because you're wildfire smoke and all this stuff, you're going to be waiting a long, long time. So I wouldn't hold my breath for that. So it is a way that you can be creative, but just know that, yeah, there are no guidelines for that right now, unfortunately.
Mm-hmm. Any additional comments on that topic?
Hi, this is Sheila Gallupo with Stanford Healthcare, and we have a lung cancer screening program. We do have some patients that don't meet the criteria, but there is medical necessity. So we have set up verbiage where we notify the referring physician and we notify the patient, and we give them the option. If their provider wants to proceed with the order, we let the patient know this may not be covered. And we've set it up in the background where we will still try to bill their insurance, or they can just go with the self-pay and be guaranteed the very low price. But in the event that we bill the insurance and it's denied, we have it set up at discounted pricing. So it's still very affordable because I've got some great case examples. Somebody who did not meet the eligibility of the USPSTO, and they found cancer. And so it was very fortunate that that patient proceeded to move forward. So there you go. Thank you.
Thank you, Sheila. That's important insight and real life applicability for everybody. Oh, we have a lot of useful information. I'll go back to that in a second, Raymond. So, staying on the topic of insurance for a moment, Cresta has brought up the topic of insurance steerage. She says, I have patients who have received largish bills from their insurance too. They meet all criteria for the annual low-dose CT. They had PPO insurance. Insurance companies engage a lot in steerage, directing patients to freestanding imaging centers and away from medical centers, despite the medical center being a lung screening center of excellence. It's frustrating. Yes, I think we agree. But comments from our panelists for Cresta and this issue of insurance steerage.
Thank you for that question. I'll take this one because we are actually actively working with community partners to enhance screening. So, Dr. Voloda shared in our story map, we have centers around us that are ACR, American College of Radiology accredited screening centers. And what that means is that they meet some criteria. They've had their scans examined to make sure that they meet some eligibility, as well as they tend to report their results to American College of Radiology registry. So that makes them an ACR accredited center. Having said that, at the end of the day, majority of even smaller community screening centers, they use similar equipment as far as machines, as far as the scanners. Some, may even have a more updated one than some of the ones that major academic centers have. As long as the patient is getting a low-dose CT, and the CT is the reality of it is there's not a whole lot of requirements there, that it's adequate. I do not have a very strong recommendation or background that the patient has to get their CT scan at a center of excellence. As a matter of fact, we're starting a partnership with a large imaging facility in Los Angeles, where we're hoping to help manage abnormal nodules as well as refer patients directly to them. Cedars-Sinai works very closely with RadNet, and we not only many of our mammograms are done there, we're sending our lung screening patients there. So, and it's true that the facility fee is a huge one for third-party payers. And so I'm not saying we should send all the patients. I think what we should not allow where they're getting screened should a barrier as far as getting them screened. I encourage my patients to go to the center that is most convenient to them, that for sure they will go, that they don't have to take a day off from work to be doing that. Make it convenient, make it cost effective both for them, and if that way it's covered by their insurance, it's fine. We'll make sure we'll follow it.
Mm-hmm. Thank you, Dr. Gandhari. And kind of along those same lines, we have a comment from Michael. It says he manages their facility's low-dose CT screening program in Shasta County, which was mentioned earlier. We're not an ACR accredited facility, and the North State identified in that map is, we pulled the ACR sites for that. Does ACR accreditation start with radiology leadership?
So thank you, Michael. Again, none of us are radiologists per se, so I can tell you that I've talked to radiologists about this. And being from a facility, so you're absolutely right. This is like great that you're from Shasta County because we called you out and didn't know you were going to be on, but didn't know you're from Shasta County. But that's absolutely right. Is that so? For example, the Kaiser system, we do not report to ACR. Okay. We used to have to report to ACR, Michael, before 2022 when it was mandated to do that. But as soon as that was taken away, guess what? We dropped out, right? Because we don't necessarily want to know, people don't want to necessarily have to report their screening rates. So to answer your question, it's long-winded, but I've talked to a couple of radiologists, and again, this is not dogma, but the idea is that it would be nice. They've said it's a benefit to have a radiology appointed lead, like a physician champion, right? Like you see us on this call, a lot of us are probably are physician champions, right? So it makes a difference. You need somebody to push the envelope, but ultimately you need your C-suite to agree to that, right? Because once you join the ACR, which I think is a great thing, that is a registry that you have to submit all your data for that will be, publicized and all that. And so there's others C-suite nuances that go into that because you will be entering your data. I mean, it's de-identifying everybody, but entering your data into who you're screening and all of that. So I do think it's important, but it's like you have to have a twofold. You have to have a radiology clinician champion that really believes in it. It's like, hey, we have a good program. We want to do this. It's almost like you do it as a positive thing. And then the C-suite has to agree too. So in our hospital system, we we didn't have either. We didn't have either. So that kind of tells you where you're at.
Thank you, Dr. Vallada. And I will just say Raymond shared some useful guidance for shared decision-making visits in the chat, and the STEPS guide, which has been referenced, also has a lot of tools for shared decision-making visits. Thank you so much for so many questions, for your engagement today. I'm going to kick it back to Bridget to go over some resources.
Great, thank you so much. And Sheila, if you could share the slide deck. Oh, wonderful, awesome. And first off, I just also want to note before I dive into resources, Sheila popped a link for a short webinar evaluation. If you could please take that, it really does help us inform future webinars and what topics might be beneficial for everyone on the call. But just to wrap up with some resources, thank you for that amazing Q&A panel. That was really great discussion. I did want to share some key resources that might be helpful in your work. First off, the resource section of our California Lung Cancer Story Map. If you go to getscreeningcalifornia.org, we do have a resource tab with a lot of the resources listed that I'm about to share. Also, the National Lung Cancer Roundtable from the American Cancer Society, they have a really fantastic resource library as well. I did also just list a few flyers about finding lung cancer early, basic lung cancer fact sheets for both patients and healthcare professionals, and then also a free online course for tobacco treatment specialists from Project Engage. We can go to the next slide. Next up, we have our Increasing Lung Cancer Screening, a manual for primary care practices, which I know Dr. Gandhari mentioned in her presentation. And then also those amazing lung cancer staging videos that Dr. Vallada also mentioned in his presentation too. You can find the full suite of videos at this link here. We go to the next slide. Here are some tobacco cessation resources, including ACS's Great American Smokeout campaign. I believe that's happening this week on November 20th, but just because it's only happening then doesn't mean that you can't promote the resources at other times. They have some great tobacco cessation information that really can be used at any point, at any time in the year. ACS also has an Empowered to Quit program, which is an email-based quit program, and then also Kick It California, which I know Dr. Tong mentioned in her presentation. We can go to the next slide. Just some more general resources. American Cancer Society has a new online cancer risk assessment. It's called ACS Cancer Risk 360 that helps individuals check their risk for cancer and also get recommendations to reduce their cancer risk, such as tips on diet and exercise and some cancer screenings they may be due for. I will say I've taken the assessment. It only takes about 5 minutes or so. So please take it yourself, share with your networks and with your patients, your communities. That would be very helpful. And also, I just wanted to mention, we do have, if you're in the LA area, there is a conference on Thursday, November 20th in Pasadena, hosted by our partner coalition. If you're interested in attending, I know Dr. Vallada might have some more information if there are any questions there. There is a QR code if you'd like to scan that as well. But we can go to the last slide. Thank you everyone for joining. These are just some photos from our membership. And again, please remember to take that short evaluation that's in the chat. And that concludes our webinar for today. Thank you, everyone.